We come together today on the fourth and the last session today in this series that we started a month and a half back with the help of Bharat Serums, where we talked about IUI, we talked about ovulation induction, and we also talked about recurrent pregnancy losses. Today, I have an August panel with me, and we're going to talk about the elusive pimpernel, the man. As we are all gynacs here, mostly, our experience and I would say our confidence of handling the man is not great. But if we step into fertility practice, the man needs to be handled gently. And to handle the man with confidence, I have with me this August panel who will tell us the very basics of what to keep in mind while evaluating the infertile man so as to be able to give them proper guidance while they go looking for a child. This, as we've mentioned, is an educational initiative sponsored by Bharat Serum, carried out by Nova IVF Fertility East. And for today, on my panel, I have four very renowned and experienced doctors. Dr. Preeti Mahawar is my colleague at Kolkata Center. She has an experience of more than 10 years dealing with both men and women. Dr. Mukesh Fogla is our guest. He comes in from Dibrugarh, Assam. He has been a leading IVF practitioner in that part of the country for again more than a decade now. Dr. Isha Sharma, she is trained all over the country and now heads the Siliguri unit of Nova IVF. And Dr. Lubna Yasmin, who is our colleague consultant at our Dhaka Bashundara Center. I extend a warm welcome to all four of you as we try and take the questions that are common to all of us when we have to face the couple in our practice. I would like to start off by reminding my audience that we are open to take questions from you. Please punch in your questions to our chat section so that towards the end of this 75 minute session that we're going to have today, we can try and answer your questions to your satisfaction. To start the proceedings for today, I call upon Dr. Preeti in that order to tell us how often does she think she encounters the man as the problem area and how does she handle the man in her clinic. Dr. Preeti. Dr. Preeti? Your mic is switched off.
Hello, am I audible?
Yeah, you're audible. So my question to you is, as an infertility practitioner, how often do you handle the man as a problem area and how is it that you approach the whole problem? Because we have been all told, and in our practice we see also that the man is a very shy animal. He feels uncomfortable coming into the clinic, talking to us, explaining to us his problems. So how do you get into the handling of the man as your patient?
See, infertility is defined as when a couple is unable to have a pregnancy, achieve a pregnancy after 1 year of unprotected sexual intercourse.
Right.
And as per logistics, we find that something around 15% couples are there which may be having difficulty in achieving a pregnancy. And as per statistics and is by practice, I've seen that male as such is responsible for the infertility maybe as 20%. And in a combined with the female or other factors at 30%, and total, if I say, it's maybe 50% of all the infertility factors I'm facing because of the male issues.
So, right. So maybe in 2/3 of the cases, the man is either primarily responsible or partly responsible for the infertility. My question is a little different. As the man walks into your clinic, he's a fidgety kind of a person. He doesn't want to stay around because people think that it is a female problem, a women's problem. As a female gynac, as a female fertility practitioner who's providing the service to your client couples, how do you make the man comfortable? How do you help him to get into the consultation room and open up to you? What are your ways of handling the man?
See, the practice practice has changed a little bit. Like when I was practicing 5 or 6 years back, even males were not coming to a clinic. They were generally accompanied by mother-in-law or maybe sisters. But now the situation has changed a little bit, that we are experienced male which is coming to the clinic and consulting with us. But still there is a little bit hesitancy. So taking a proper history, and in order to make him feel comfortable, what I do is basically a detailed history and maybe semen analysis, which, and if I get one good semen analysis without normal female and semen analysis, I will be reassuring the man that his parameter seems to be okay.
So you would mean to say that the first time that a patient walks in, you will take a detailed history for the couple and then would request for a semen analysis in your first visit. I don't really think that most men are ready for it. Dr. Lubna, what's your impression practicing in Dhaka? How often do you recommend a semen analysis in your first visit to the couple? How is it that you first give some medication to the female patient, treat them with kid gloves? How is it that you handle the man? Do you go ahead straight away and order a semen analysis, or do you something else to them?
Really, from when I started practice in infertility, I try to give if I want to do a single test, the first and foremost, I like to do a semen analysis.
Right. Because but is the man ready to get the semen analysis done?
I try to counsel as far as possible.
Very good. So you try.
I'm convinced, they're pretty convinced that if after explaining the thing that both are necessary and they're doing test male part initially, that is actually safe for the patient, because the male has a single test that will define he is okay or not. But in case of female, we have to go through a lengthy process, step by step.
So that's a wonderful point that you are making, that when we make it clear to the couple that while you have to do only one test to help you out, to find out what is the reason, the female has to be subjected to multiple tests, ultrasound, blood tests. So why don't you go ahead and do this very simple test, and we can try and come to the conclusion faster. That's a wonderful way of doing things. Dr. Mukesh, have you faced a resistant man in your practice? Man would refuse to get a test done. He would say, no, it's not my problem. You treat my wife and that's it. How do you handle the man in your practice?
This is a practical problem, and I think almost 2 to 3 husbands out of 10 will have provide some kind of resistance to being tested, because as we all, it's the general psychology of the male. It's a male-dominated society that they feel that I have proper intercourse, I have proper ejaculation, my semen volume is good. So they have a misconception that once they have a otherwise normal sexual life, they think that semen must be normal, but that is not fact. So resistance is there, but as Dr. Lupa has well explained, that it's all counseling. Patient needs to be explained that you need to see your sperm under the microscope to know whether it's normal or not. But still, few are there who will insist. But in that case, we do not. We are not being very rigid and give them some time. And in the next couple of visits, ultimately they understand and agree to do a semen analysis.
That's another wonderful way of looking things, allowing the man to ease into the system, because he's waiting outside, he's talking to other couples also. Once they get a sense, now this is essential and this is part of the whole regime, then they can get themselves more accustomed to handling the whole thing. Quite obviously, there is also this cultural change that's come into practice, as Dr. Preeti was mentioning initially, wherein now we see less and less of resistance and more acceptance of the fact that infertility is a dual or a couple responsibility and not necessarily a female responsibility. Coming to the definitions as such, Dr. Isha, male infertility, does this include only a seminal problem, or that includes sexual dysfunctions also? How is it you define a male infertility? What all constitutes male infertility?
So male infertility can be because of many reasons. So it can be because of any abnormal in semen parameter, as well as sexual dysfunction like ejaculatory or erectile dysfunction. These can also constitute a part of male infertility.
So for the benefit of my audience, we are not discussing sexual dysfunction today, because we have now kept it in the realm of the andrologist, who is basically more well-versed with dealing with sexual dysfunction part. So our discussion today is mostly organic and functional issues that we'll be discussing. How important do you think is for us to know about the man in fertility practice? What is the necessity other than the semen analysis? What else do you need to know about the man so that it can be helpful in the in the practice of infertility, Dr.
So,
Isha?
sir, if after doing semen analysis, if we find any abnormal parameters, so we have to first reason out what might be the cause of these abnormal semen parameter. If there is any correctable factors associated with these abnormality, there are tendency that we can correct those factors, and later on patient may have a normal semen analysis, then can have a may help in conception also. So these factors are very important to know. What are the factors associated, whether it is treatable, not treatable, and depending on that we can counsel the patient. You
Which
may
is
take
also, I would say, which is also, I would say, an important part of the first day counseling, as Dr. Preeti was saying, to reassure the man that if the semen analysis is carried out and the report is good, then you are in the clear. Even if the report is not good, maybe we can do a couple of other tests and then tell you what may be done to you to help you to conceive or get your wife pregnant faster. So that kind of thing is very important. What are the prognostic factors? Like, how would you say that this is a easily treatable man and this might require some higher order treatment? What are the prognostic factors for male infertility? Semen analysis report is obviously the most important thing. Other than that, what do you think is important when you're counseling the couple? What would make you think that this is an easily treatable couple from the man's point of view?
Okay, so it depends on how long is the fertility, what has been the duration of infertility, if any associated factor is present in the females or not. So
of course, a fertile female makes for a easier couple, because
Yes.
if the female does not have any problems, then maybe the pregnancy rates are higher. That's also an important point.
And also, sir, depending on the semen analysis, what is the what are the abnormal parameters? Like if there is azoospermia, oligos, because the treatment patterns are different for each of them. So depending on that also, we can ensure whether the chances of conceptions are there or not. And also if there's any physical abnormalities like varicocele and all, which are treatable. So these factors also helps in conception.
Thank you, Dr. Isha, for pointing out varicocele and other factors. But I have a very simple point to make. How often do you people actually go out and do a thorough physical examination of the patient? That is something which I would say is discrimination primarily, because the female patient is subjected to a minutest of examination. She undergoes an ultrasound on the day of visit, then maybe again on the first day, the second day of the visit. I would like to tell my audience here that I have had cases where the man has been sitting on orange size hydrocele and nobody has even bothered to examine that patient before referring that patient for higher order treatment. So it's understandable that given the scenario that exists in our country and even in Bangladesh, there is a pronounced gender bias. Most fertility physicians are female and are not very comfortable carrying out a male examination. I think it is very important to point out here that other than a history taking and a preliminary semen analysis, a physical examination should also be part of the routine armamentarium, and that examination can be carried out by your doctor colleagues like a urologist or a family physician, but some sort of an examination should be carried out so that we don't miss out on very valuable pointers. As Dr. Isha said, a varicocele may be missed out till towards the very end, which is something which is not fair to the patient. Any other points that any of my panelists would make on this point? Dr. Isha, how do you handle your male patients? If you do not examine, how do you do a complete...
Usually, as Dr. Lubna and Dr. Preeti also stated, that at the first visit, it is very important to explain what is what is the importance of semen analysis. If the semen analysis happens to be normal, I usually don't send it to any andrologist.
Which is a very fair thing to do.
Any
If there is no
abnormality,
sexual dysfunction and the semen is analysis,
so
they're pretty much
if there's
considered
any
normal.
abnormality, I send the patient to urologist and also ask them to come back and get the review done, whatever, because sometimes there are change. The way they treat is quite different to what we do.
No, I would suggest that the treatment should be your domain. The
Yes, sir.
examination can be carried out by
Yes, sir.
your
Yes, sir.
urologist partner. Unless that person is a trained andrologist, I would not really park my patients with my urologist partners because their knowledge of fertility practice may not be very up to date.
Just for examination, sir.
Just the examination by them, I think, is a very fair practice, and that's a take-home message also, that in case the semen analysis is not good, before we proceed to other tests, it makes sense to have them evaluated by your colleagues. Dr. Preeti, I'll come back to you. When you're taking a detailed history, as you mentioned in your initial comments, what 2 or 3 points are you looking for? I don't want a whole detailed five-page answer on this. A couple of points that you think are necessary to elicit from any man if he is saying that he is having issues having a child.
See, first of all, as you said, there are few prognostic factors. I would like to ask them these prognostic factors about. Then between the history, I would like to basically take a reproductive and sexual history, like what is the frequency of the intercourse, what is the duration, what is the timing of the intercourse, erection, ejaculation problem where they are having. Then among the medical history, any associated diabetes or hypertension,
So
and surgical history of
diabetes and hypertension are two associations that you always ask for. Anything else that you look for? Medical history?
medical history. Definitely look for hypertension, maybe sexually transmitted disease also.
Okay.
There could be history of tuberculosis also.
Okay, and
And
surgical
among
history?
the surgical history, maybe we are looking for repair of herniorrhaphy, or maybe a varicocele operation in the past, or maybe an orchidopexy done in the childhood.
So any pelvic surgery
And,
in the past, pelvic surgery in the
yes.
past. We also take a thorough drug history or a chronic medication history, because we know that certain medications like sulfasalazine, etc., may have a detrimental effect on the semen sample. Going ahead with the semen analysis, I would like to ask you this very specific question. When do you offer a semen analysis to your patients, and where do you offer your semen analysis for the patients?
Well, semen analysis is generally offered after 1 year of infertility when they are complaining. But in case the male says, I have some problem, then we go for early evaluation. Maybe the age of the woman is 35 years. She's having complaint like which points about the endometriosis, painful periods. We may go for early semen analysis. And semen analysis is a thing. I will not go for just one single report. I will at least go for 2 or 3 reports if they are available. And it's better and the best if it is done in my center, because we are following WHO semen analysis. So it looks all the factors which is important in order to assess the fertility possibility or probability in that patient. So I'll also, every time I go for the WHO criteria.
Dr. Mukesh, what is this WHO criteria? Why is it that it is important to carry your semen analysis from a proper place? What is your understanding of the semen reports that patients bring from all kinds of places? And can you just kind of elaborate on this for the benefit of my audience as to why is it very, very important to get the semen analysis done from a proper place? In fact,
WHO
it says
in
here,
2010.
Yes, please go on, please go on.
WHO in 2010 revised the criteria. The main aim was to standardize. Main idea was to standardize the reporting of semen analysis all over the world. The most important thing what they came up with was the change in their morphological diagnosis, in the sense that they brought down, they followed the strict Kruger's criteria for assessment of the morphology, and brought down the normal values of morphology to 4%. And for that, a very standardized method of assessment of morphology needs to be followed. And your whoever is doing the analysis needs to be trained and taught properly in a proper way, so that the assessment can be done. So I think the idea was to standardize and to make it more strict, so that we have better idea of.
So for the benefit of the audience, I'll just like to point out what has been defined now as the lower reference limit. They have done away with the average or the normal values. They have now defined the lower reference limit. And they say that the volume of more than 1.5 ml, a total count of more than 40 million, a sperm concentration of more than 15 million per ml, a total motile count of more than 40% is good enough for a person to father a child. The only controversial area, as Dr. Mukesh pointed out, is that the sperm morphology has now been defined as 4% normal sperms is considered as a good semen sample. Previously, of course, as we know, there was a huge difference. This is one slide I'd like to bring to the attention of everyone, including the audience, that previously the morphology was defined in 1980 as 80% sperms have to be normal, and that then came down drastically to latest 2010 criteria, where they're saying only 4% normal sperms is good enough. Other parameters have also been revised downwards, but this has been a very, very drastic revision downwards, which effectively says that only 4% of the sperms which are analyzed in the lab, if they are normal, then that's good enough. But this is very important for the audience to understand that by this 4% analysis, we are talking about a method which is known as Kruger strict criteria, which was defined by Daniel Franken and others. And this is a very strict method of evaluating the sperm under a high power microscope, where they look at the head, the shape of the head, the tail defect, the neck defect, and they are very strict about telling us which is a healthy sperm or normal sperm and which is not. And this is a practice which is more of the benefit to the IVF centers, because in IVF centers, this may help us to differentiate between people who have a higher chance of failure or miscarriages rather than with people, the normal population. I'm of a personal view that this does not have much of an application on a universal screening method. And even as we speak today, 95% of the labs across the country and in Bangladesh are still doing analysis based on the past methods. So which is why there's a huge gap that we see between our reports, which are given out by IVF centers, where the morphology is said to be 2% normal or 3% normal, and other reports which say 60% normal or 70% normal, and the referring gynac is confused and the patient is confused, and it takes a lot of counseling effort at our end to make them understand that this is pretty much the same thing. A normal microscopic report of 60% may be the same as the 3% that they found in our lab. So this is a very, very important take-home message as regards to the new semen analysis method. A couple of other points also we would like to mention here, and I would like to bring this to the notice of the audience through the efforts of Isha, Dr. Isha, is that what is her impression as to what are the different types of seminal defects, meaning what is an oligospermia, what is asthenospermia, what is teratodospermia, and why it is not always the right thing to look at the count and ignore the rest of the report. Why should we look at everything? We should look at the morphology, we should look at the speed, the motility of the sperms, and also on the count. Dr. Isha, will you elaborate on this?
Sure. Oligospermia, when, as we saw in the previous slide, it is when the sperm count is less than 15 million per ml. Astheno, where the motility, basically we look for the motility, which is less than 32%, and teratozospermia, which is less than 4%. Basically, oligospermia, because some certain amount of sperm is required in order to penetrate the oocyte, so that there is fertilization. So this is, they have standardized that this is the minimum 15 million. That's why it is important. And also the motility is very important, because if the motility is decreased, because since the sperm has to travel from the cervix, from the uterus up to the ovum, so if the motility is less, so then this fertilization process may be hampered.
I understand that, but I have a different thing. Many people have come back and told us that you need only one sperm to fertilize an egg. Why do you need so many sperms? So can you just explain to everyone as to how does the count, the motility and morphology affect the outcome? What happens when the count is low? What happens when the motility is not so good? And what is the problem when the sperms are not healthy looking?
So since it has to bypass the cervix, because there are many factors it has to cross. So there are chances, suppose if the man is having more than 15 million, by the time it reaches the
So you have to start off with a large number of sperms because the vaginal pH is bad, and that affects the sperms and it does not allow most of the sperms to survive. There is a regurgitation of semen after sex, so most of the semen actually flows out. So even if you start off with millions of sperms, very few sperms are actually left in the cervical tract to bypass the cervical mucus, enter the uterus, and that's why the number is important. What about the motility?
So motility also is important because with motility, basically motility is provided by the acrosomes when it goes and attaches into the
So motility,
oocyte.
according to you, is also a parameter of the function of the sperm. So if the motility is good, then it can be expected that the function of the sperm will also be better.
Yes.
And teratospermia can, of course, explain if the sperms are not healthy looking, then they may be carrying damaged DNA inside.
DNA.
So that may lead to miscarriages or failed fertilization. What is cryptozoospermia? What do you think is cryptozoospermia? Because we hear of these terms very often. So what is cryptozoospermia?
So supposedly if after semen analysis there is evidence of azoospermia, but once if that is after the semen is run into a centrifugation and after that we get the sperms in that sample, that is known as cryptozoospermia.
Okay, so basically when in raw sample you don't get any sperms, but after centrifuge, if you find some sperms, then you call this a crypto. So basically very few sperms are there, and this is almost like a azoospermia sample where there are no sperms, but in some cases you might find a very few sperms which may help you to get a pregnancy. I would go to a little more discussion about the semen analysis because my audience needs to understand how critical it is. So for the first time, WHO recruited almost 2,000 men who had become fathers in the last 1 year. And these men were then asked to give samples, only one sample per person, in 7 countries across 3 continents. And that sample was analyzed in standardized quality control labs. And that's how this kind of reference values were created. So I personally feel that this is a very reliable parameter to look at because for the first time, there was a standardization of semen analysis and a heterogeneous population was studied. So these are the best, I would say, the plus points about these kind of parameters that have been released around 10 years back. They also selected people who had children themselves. So that's the best proof that these sperms are healthy. There are certain demerits also. Quite obviously, semen analysis is an evolving story. And maybe the next parameter would be an even better parameter. First of all, they only selected 7 countries. So maybe next time around, more countries would be, more ethnicities, more races would be included to get a better idea. Or maybe there could be an ethnicity-driven semen parameter that could be defined. Again, morphology is still not very clear because very few people are trained on the Kruger strict criteria to really come back efficiently and tell us that the sperms are not good looking. And only one semen sample from each individual was taken. As we all know who practice infertility, that there is a huge variation in semen samples across samples. So there should have been some sort of a standardized 2 sample or a 3 sample, and then an average should have been taken. So these, I would say, are still drawbacks, but there's nonetheless, semen analysis remains the first lab test that a clinician would order. And we have to remember that even though at times the semen analysis report is all right, even then there could be some hidden factors which might make us wonder that maybe the semen sample is not good enough for a pregnancy to happen. Now, when we ask for a semen analysis, Dr. Lubna, has your technical problem been taken care of? Dr. Lubna is...
Yeah, okay. Now okay, I can see. Okay.
Okay, fair enough. Thank you. So this question goes to you. So when you order for a semen sample, as Dr. Preeti also mentioned, that you are looking for finding out whether the man is suffering from a problem. If the problem is there, then how significant the problem is, and what can be the reason for this problem? How can we sort out this problem? This is the reason why I do the semen analysis. But there are so many other things that we need to understand. Do you think a semen analysis helps you to decide whether you want to take the patient for an IUI or an IVF? Do you think that the semen analysis helps you to decide whether they will not have miscarriages? What else can be obtained? I think you are having 2 devices running, so have only 1 device running, Dr. Lubna. Right.
That device was stopped, so I
Yeah. So the question to you is, does the semen analysis help you to understand whether you want to do an IUI or an IVF? Does it help you to understand whether this patient will have miscarriages or not? And does it help you to understand whether there is a reason for unexplained infertility? How does a routine semen analysis help you other than the points mentioned?
Actually, routine semen analysis we are doing first to know the overall is there any abnormality, and the semen analysis if okay, then the things go in one way, and if the first semen analysis is wrong, then we do the next one after 4 weeks interval, and then actually we have to classify the a patient or the male, either what may be the cause that
No, my question is different. My question is, based on the semen analysis, are you able to tell us whether there will be a less risk of miscarriage or whether the patient will be benefiting through an IUI or through an IVF? What all information do you get from the semen analysis in case the semen analysis is not optimum?
Actually not, we cannot say properly that because in semen analysis don't give us any functional status of the sperm.
Exactly. So that's my point. Exactly. So that is my point. So while semen analysis gives us some chartered accountant numbers, what is the count, what is the motility, what is the morphology, even now a basic semen analysis leaves a lot of gaps which a clinician has to still fill up. They have to ask for specialized tests, and which is again not carried out on a routine basis, which are not standardized. There are a lot of confusions regarding when to do these tests and how to do these tests. But unless we do these tests, we really cannot comment about a few things. Like we cannot tell you about the possibility of a miscarriage. We cannot explain unexplained infertility if the semen count is normal, and so on and so forth. Dr. Mukesh, I'll come to you on this. I understand that you do not do DNA fragmentation on a routine basis. But going forward, let us say if DNA fragmentation kits were available for a cheap and a standardized method was available, then would you recommend a DNA fragmentation for all? If yes, then why? And if not, then who would you recommend it for? Dr. Mukesh, this is your question.
So I think it's a hypothetical question. It's a hypothetical question.
Absolutely,
right?
Absolutely.
As on today, we are not doing DNA fragmentation. Number one, because it's not standardized. Every second,
which is a very important point
has its own method.
Absolutely. Please go on.
DNA fragmentation. Number one, there are 4 different types of tests. Out of that, again, every lab has their own reporting system and cutoff values. So there is a lot of confusion. But DNA fragmentation basically is more indicated in cases which are having repeated implantation loss, repeated implantation failure, or recurrent pregnancy loss, because it has been seen that the DNA fragmentation basically it does not interfere much with fertilization or pregnancy, but they come into effect more in the later stages of embryo development, and they ultimately
these are extremely valuable points, Dr. Mukesh, you have made. That DNA fragmentation is not a routine test, should only be carried out to explain failures, whether it's an implantation failure or a miscarriage. And DNA fragmentation may not interfere with fertilization, but may interfere with subsequent embryo development. So while DNA fragmentation is a good test to have, it is not a standardized test and should be reserved only in such cases. I think these are very valuable points that have been made by Dr. Mukesh. Dr. Isha, in the last 5-7 years, a lot of pharmaceutical companies have come up and promoted nutraceuticals for ROS of the semen sample. What is ROS? How is it important? And what is your take on ROS in semen sample?
So ROS are reactive oxygen species. Actually, it is present in a balanced form in the scrotum, like in the testes in a male infertility. So there is a oxygen species present as well as scavengers present. So if there is any imbalance in these, they may lead to increase in oxygen species, which may affect the quality of the sperm. It mostly it causes the DNA damage. So basically, there are substances which, like as we give in, as we see in antioxidant like vitamin C, vitamin E, zinc, selenium, they have antioxidant property which may help to control the reactive excess amount of reactive oxygen species present in the surrounding. So
Do you check for ROS in your semen sample as
no,
a
no,
routine?
no. No, sir. Usually, if there is any evidence of abnormal semen parameter like oligospermia, asthenospermia, as well as teratozospermia, which reflects there are possibility of reactive oxygen species. So in those cases, I give antioxidant for around 3 months. Then I see the semen analysis if there is any improvement or not. If there is any improvement, then the possibility of oxygen, and
So we
also
have
if there is.
thank you, Dr. Isha. So we had two hypothetical discussions. One on is the ROS, presence of ROS in semen sample and causing damage to the DNA of these sperms. And the second is the estimation of DNA fragmentation. Both of these are putative or assumed or empirical situations which we don't test for as yet on a routine basis, but we assume as one of the reasons for failure of implantation or miscarriages, or let's say poor count, as Dr. Isha said, and then we try and treat it with antioxidants. We will come to treatment modalities a little later. Dr. Preeti, to complete the evaluation of the male partner, of course, we talk about the physical examination. We talk about looking at the urethral meatus, the size of the penis, the size of the testes, and so on and so forth. We also look at the post-ejaculate urine sample to find whether there's sperms there, because in some cases there could be retrograde seminal ejaculation. We'll come to it a little later. What about doing blood tests and ultrasounds for these patients? Dr. Preeti, your take on this?
First of all, we come to the semen analysis report. So in the semen analysis report, if we find that the sperm concentration is less, maybe less than 10 million per ml, or the male partner's complaints of maybe impaired sexual functions, or there's some specific findings of a specific endocrinopathy, in that case, we generally asked for the blood test. And among the blood tests, generally,
what all blood do you test?
If minimum I am asked, I generally go for FSH and testosterone. But if I have a liberty to do other tests, then definitely I'll go for FSH, LH, testosterone, prolactin, and estradiol. Prolactin, estradiol, especially if there is some sexual impaired dysfunction. Okay, and so in order to classify these things,
please go on. Yeah.
Yes, maybe a thyroid, TSH. Maybe a sugar level HbA1c will be able to analyze them more nicely. And we then divide them into maybe 3 or 4 parts. Like if we find FSH, LH and testosterone to be normal, then we tell them it's a normal spermatogenesis. If all of them are low, that means FSH, LH and testosterone are low, it points out towards the diagnosis of hypogonadotrophic hypogonadism. And if we find that there's an abnormal spermatogenesis, in this case, generally the FSH is high, the LH and testosterone can be normal. But if it's a case of complete testicular failure or maybe a hypogonadotrophic hypogonadism, in that case, both the pituitary hypothalamic hormones, that means the FSH and LH going to be high, and testosterone may be normal in such a cases. And if it's a prolactin, then the prolactin will be high.
So all these kind of grades always confuse me because I was very bad in mathematics. Just for my understanding, what's your FSH cutoff? If the FSH is less than this, then it is a hypo. If FSH is more than this, then it's a normo. And if the FSH is more than this, then it is a hyper.
I generally go with the FSH of between 2 to 7 is normal. If anything more than 7.6 or 8, I'll go, it's a high FSH.
So
and
for our
understanding,
an FSH in double digits is always a warning that the person might be going into a testicular failure. Whereas if FSH value is less than 2, that person may be sitting on a hypo. This is again as a ready reckoner. Obviously, there are debates about the numbers, the values, and so on and so forth. But for the practicing clinician who has no time for all this is a ready reckoner to understand. Similarly, for testosterone values also, if the testosterone is low, then there could be an end organ failure. If the testosterone is normal, then there is no end organ failure. Just as for our understanding. Do you carry out imaging as well, Dr. Preeti? I already have a couple of questions where they've talked about vasography. So do you carry out vasography for your patients? Do you do a scrotal ultrasound? Do you do a transrectal ultrasound? Anybody in the panel, I open this question to everybody in the panel. Does anybody in the panel carry out a routine ultrasound? If yes, then when? And if not, then why not?
Sir, I usually get it done when if there is any abnormal semen parameter to see if there is any local defects or anything like in azoospermia, oligospermia.
What is it that you look for? You look for a scrotal ultrasound or a transrectal ultrasound?
Scrotal ultrasound I go for.
Okay. Anybody else in the house? Any other opinion? Dr. Mukesh?
I think
scrotal ultrasound would be
different issue.
I generally
Dr. Preeti, please.
Generally the testes can be examined in the scrotum with the help of a palpation, but only if we find there's some filariasis or maybe some hydrocele where it is difficult
unable to examine
palpate
the testes, then maybe we'll ask for an ultrasound.
Unable to examine.
Dr.
Yes.
Lubna?
Maybe undescended testes may be helpful in this cases.
Transrectal ultrasound usually, I think, when I have a suspicion that there may be ejaculatory duct obstruction.
So when there is no sperms and the volume is low, then you would like to do a plus to find out whether there is a ejaculatory duct obstruction. Thank you for the smart pinpointed messages on this, Dr. Mukesh.
I wanted to add, as our female colleagues are not doing a physical examination themselves, they can ask for a scrotal ultrasound. I think that can be a little more, give them more confidence. Apart from their colleague examining the male partner, ultrasound report can be, I think, also added upon on that. We have
at least that will rule out the orange size hydrocele that I talked about in the patients. So that's something that we can keep in mind. Absolutely. So this is kind of a summary as to when you want to test your patients. This is how you test the patients. I will not have you go through the slide once again, doctors. It's quite self-explanatory. We'll move into the next section, that is the more exciting section, the medical treatment options. So there are certain counseling points. Before you start treating them, you talk to them about lifestyle measurements and all that stuff. Dr. Preeti, you're so wonderful in explaining things to patients. What are your counseling points, 1, 2, 3, 4, to the man before you actually start specific therapies?
First of all, if after examining the semen sample we find everything is normal, I would always encourage them to have a natural pregnancy. In that case, I have to tell them about the time intercourse, what is the period of ovulation, and give them support in case of any problem they are facing, and also to explain that the condoms which are used and stop not to have a lubricants which are spermicidal in nature.
That's very important. Any kind of a lubricant has some sort of a chemical, if not a chemical, at least the odor producing, the smell producing perfumes are there which cause damage to the sperm. So that's something that should not be used. Anything else, madam?
If there are some semen parameters deviation and we find during the history that there's a smoking habit or they may be taking alcohol, we have to tell them not to take the alcohol and quit smoking. Probably if they're suffering from obesity, we have to ask them for the weight loss, give them methods, maybe make a diet chart from them, and also avoidance of heat in any measures, like avoiding saunas, avoiding some maybe wearing loose undergarments. All these things, they should be advisable.
I would also like to add here that many men do exercise and gymming, so they take those protein supplements and testosterone injections and tablets. They should stop using them as well. There's another very interesting point mentioned in the slide, that men older than 40 and women older than 35, they should also be counseled about the possibility that there's a higher risk of genetic abnormalities in the child. In fact, I read somewhere that if the man is more than 40 or 45, the child has an equal risk of an abnormality as a woman giving birth after the age of 45. So that's food for thought. So even older men do not have it as easy as we thought it was. Abnormal findings, if there are there, of course, then we carry out physical examination, we do other tests as well, and if we find other issues, then we try and treat them. That's understood. What about medication? Dr. Isha had mentioned initially that she puts them on antioxidants. So what's your favorite poison? What's your dose? And how long do you continue your antioxidants?
Actually, nowadays we get antioxidant with all added nutrients. So we usually give that for around 3 months because that is the duration where that is the time taken for spermatogenesis. So minimum of 3 months we usually give for these kind of cases. And supposedly, if we see a low oligospermia, it has been seen that giving it. There are studies which shows giving a clomiphene citrate as well as letrozole may improve the quality of these semen parameter. But there is controversy regarding it. So if the pituitary is intact.
No, we'll talk about the medications a little later. I'm asking about the antioxidants primarily. Anybody else in the house, what's there? We all write antioxidants. So there's no denying the fact. Otherwise, we would not have 40, 50 companies coming in every day to force us to prescribe antioxidants. So that's not that we don't write. What is our experience at having made the patient spend so much money? What is the benefit that they get? Dr. Mukesh, Dr. Preeti, Dr. Lubna, do you write antioxidants?
I write antioxidants.
Please.
I write antioxidants just to buy time, to be very, very honest. Because once you have an abnormal report in hand, the patient obviously expects some kind of treatment being initiated. And in that case, writing some sort of antioxidants does not do any harm, builds up the confidence of the patient. And in the meantime, we have time to evaluate the female partner, to have a detailed investigation, and also to recheck the semen after 2 months or 3 months, and then being more confident about the diagnosis. So I am using antioxidants.
That's very correct. That's in fact a very logical way of looking at whole thing. That we write medication, give them a sense of a placebo while we evaluate the couple and try and get them to understand the whole process of reproductive medicine. Dr. Preeti, do you write antioxidants? Are you happy using them? What's your experience like?
As such, if you talk about the COVID, there are no as such specific treatment for the COVID treatment. So you prescribe a lot of anti-malaria, maybe antioxidant, maybe antiviral, just to have a thing. So even in the same scenario, we don't know what is the specific role of these antioxidants. We don't know the proper dosage. We don't know the specifications of each capsule. So just as Dr. Fogla said, we are buying time and we are just reassuring the patient. We are in the meantime, we are doing some tests to find out whether this is correctable or not correctable. So I prescribe antioxidant, but in case of mild male factors where I find it can going to be help, and during the history taking, I find there's a varicocele, maybe obesity, or maybe where the
even the Cochrane review is not very confident about giving antioxidants as a treatment modality, but in real practice we have to do this because then that's how we can actually hold on to our patients while we take them to definitive therapies.
Sir, also
yes,
in
please,
cases of
Dr. Isha.
If there is if there is a normal semen parameter, there might be chances of DNA, loss of
This
DNA.
is again a very valid point. Valid point. Yeah.
So which cannot be recognized in a normal semen parameter. So in order to in these cases also we can give to see if maybe sometimes there are cases where even just by giving an antioxidant patient have conceived.
So that's absolutely true, and I'm so happy you're talking all honestly here, that in our lives we have all seen anecdotal evidence that people have benefited with DHEA and people have benefited with antioxidants. So we cannot really desist. At the same time, there's so many things that there is a theoretical reason why it may work. Although we may not have that proof in real life situations, but there is a theoretical evidence that antioxidants may work. And we want our patients to have that benefit while we prepare them for definitive therapy. So that's a very, very nice take-home message that I get from my panel here. There are other interventions like bariatric surgery, weight reduction, tobacco cessation, alcohol moderation. Dr. Preeti said, I'll make them stop alcohol. That's very difficult, madam. But yes, cessation of tobacco as far as possible and all alcohol moderation, caffeine intake, all these are there in complementary alternative medicine therapies that we all practice, although the evidence is not very strong in any of these. Coming to more definitive management, giving them HCG injections, giving them letrozole tablets, giving them estradiol receptor modulators such as clomiphene. Dr. Mukesh, You were talking prior to the session that you give letrozole to your patients. Who is your letrozole candidate and who's your clomiphene candidate? And what's your experience like?
Basically, I give letrozole only to my obese male patient because the obesity is, it's a pandemic, obesity. And because of the excess of fat deposit, we all know that testosterone is peripherally converted into estradiol, and estradiol has a negative effect on the male reproductive system. So before giving letrozole, I always make sure to measure her testosterone and estradiol levels. And if I see that on the higher side and testosterone is on the lower side, then letrozole 2.5 milligram daily for a 3 to 5 months works very well. In the meantime, you have to ask your patient to lose weight. Okay. And clomiphene citrate used as it was abundantly used around 3-4 years back. The use of clomiphene citrate has come down drastically. But if you are using clomiphene citrate, you can use only when you see that the FSH, LH hormones are little on the lower side. Testosterone are also on the lower side. So that basically what CC will do is stimulate your pituitary release of FSH and LH. And in those cases only clomiphene citrate may have some effect. Otherwise, I think there is no use.
And what's your dose for clomiphene citrate? Because I have questions coming in from the audience, and this is one of the questions that we can address right now.
Clomiphene citrate is used at the dose of 25 milligram either daily, or it can be used on alternate days, 25 milligram alternate days or 25 milligram daily.
Again, for the same 3 to 5 months, is it?
3 to 5 months.
Okay. So these are again very, very important points. In real life, yes, we put them on letrozole if they're obese. If the testosterone estradiol ratio is is less than 1:10. Similarly, we put them on clomiphene also if there is a mild parameter affection with the hormones being normal or low normal. These are the candidates. These are wisely chosen candidates, and they are also prospectively counseled about the fact that these medications may or may not work, and they should be prepared for higher order ART in case these medications do not have the desired effect. So that's very important that we should combine that with proper counseling of our couples. The recommendation by EAU, the European Guidelines of Andrology, is that use of medical treatment is only for hypo patients where we use HCG or HMG injections, and no recommendations can be made as of now for gonadotropins, anti-estrogens and antioxidants, even for a subset of patients. But then these are not medications in the strictest sense of term, as we've discussed in the past 15 minutes. This is more like a placebo. Sometimes there are anecdotal evidences that it may work, absolutely sure that they're not causing any harm. At the same time, they're psychologically preparing the couple for the higher order ART that they might need or benefit from in the next 6 months. Surgical options. Surgically, does anything work? Do we do any kind of a corrective surgery? What is the role that we do in varicocele? I don't know who will take this question. Dr. Lubna, would you want to take this question? If not, then anybody else. Please, Dr. Lubna. So do you offer surgeries for your varicocele patients?
Varicocele surgery, it depends. If there is semen parameter is problem, that means that's abnormal semen analysis and clinical varicocele.
So this is very important. The varicocele has to be clinically detected and not ultrasound detected, and there should be a spermopathy of some sort for us to go ahead and recommend a varicocele surgery. The surgery has to be microsurgical in nature, has to be as less invasive as possible, and then we should also prospectively counsel our patients that there could be a benefit or there could be no benefit arising out of the surgery. Post-surgery, what is your plan of action?
Subclinical varicocele, no semen abnormality, we never do varicocelectomy. And
very good. So after surgery, what is your plan of action?
The thing we have to, after varicocelectomy, usually sometimes it happens that sperm appears in the ejaculate. But
if it was an azoospermic person, then maybe there could be some sperm seen in the ejaculate.
We have to keep in mind. Yeah. Okay. If the varicocelectomy is the only cause, if the varicocele is the only cause, there is no other factor of infertility, male infertility factor, Then after varicocelectomy, we
Last couple of years, a few evidences have been published where they have aggressively promoted varicocele surgery for azoospermic men also, people who have been posted for ICSI, saying that post-surgery the sperm quality has improved. So that's something that needs to be taken as food for thought, that sometimes maybe the surgery helps in improving the sperm quality and therefore the overall outcomes. The next question I will continue with Dr. Lubna. Once you have looked at the semen sample and you think it's a mild semen sample and you want to post them for an IUI and they want to know from you what's the success rate and how often do you want to do your IUIs. So what is your mild male factor IUI all about? When do you recommend an IUI for men, for problems with men? What is the kind of results that you expect in such couples?
Actually, IUI is a very popular fertility treatment. First
And
line
easily
fertility
digestible. The couple is willing to take that treatment.
Yeah. And people who are thinking getting child of their own gamete, that means using their own sperm, own site. So this is their first choice IUI. Though the success rate from the very beginning till now, even so much upgradation of semen analysis or anything, the success rate is poor IUI. And for actually, I work the cutoff count, that is according to WHO. We know that the lower limit of cutoff value is the 15 million per ml. But I will consider for IUI in case of if the parameter is more than 10 million per ml. Okay. And in case of motility,
so for
usually
mild abnormalities, you would go ahead with an IUI.
Mild abnormalities.
And what is your counseling like about success rates? How often will you do it? How many times will you do it? And what is your expected success rate in such couples?
Our expected success rate usually 8 to 10%, and I usually counsel the patient to ready at least try for 2 or 3 times, because that is the cumulative success rate is good.
Okay. Okay.
Because
So while the successes are not good, are not very high, at least the patient can benefit from a simple treatment modality. And if they do get pregnant, they are always grateful to you. So these are again very, very valuable practical points from Dr. Lubna. And I wish you all the best in your male factor infertility patient treatments as far as IUI is concerned, because my personal experience, unfortunately, is that most of these patients do not benefit from IUI and they have to move on to ICSI. My next question, again, open house to all of you, is, are you now doing ICSI for all? If yes, then what is your reason for doing ICSI for all? And I have heard that people use testicular sperms even when there are few ejaculate sperms available. What's the thought of the house on this? And what's your experience? And this is a very sensitive question. There are so many people, there are so many publications which talk about the ICSI children not being as healthy as normal children. What's your personal experience about the so many children that you've all had through this procedure of ICSI? Dr. Preeti, I start with you.
Well, initially when I started my practice, it was ICSI for all. But nowadays, ICSI, I'm not doing ICSI for all. It is maybe for testicular sperm, maybe when there's a IVF failure in the previous case, or maybe there's a oocyte which has been frozen, or maybe sperms also, maybe for OAT. In all these cases, I'm doing ICSI. And the case which you asked, like when we prefer testicular sperm, even when the ejaculated sperms are there, maybe in a previous case of IVF failure, when we pinpoint towards the DNA fragmentation of the sperm is high, in that case, I like to do testicular sperms for ICSI. And my experience with ICSI children is almost there. All of them are very healthy and everything. But one case was there of hypospadiasis, which I got.
Okay, so that's again a very reassuring piece of news from Dr. Preeti. I move on to you, Dr. Mukesh. What's your experience with ICSI children? Do you use testicular sperms, and do you do ICSI for all?
We do ICSI for all.
Okay, and confident, bold answer.
Yeah. To be very honest, this complications in children out of ICSI is very hypothetical. I have not faced any serious complication till date, and there is no literature which says that ICSI children are at a disadvantage or they are having more complications. There may be some sporadic report here and there. But once you do a IVF and there is fertilization failure and the patient asks you what has happened, why the eggs did not fertilize, now what will happen to us? We have spent so much of money on stimulation and other procedures. Then you are little disappointed, the couple is disappointed, you are disappointed, and it is very difficult to answer their questions. Medically we know this is possible and it happens, but on practically it becomes very difficult to answer and to digest the news. So end of the day you have to have some protocol so that you feel safe, your patients feel safe. And after going through all this experience, ultimately we decided to follow the protocol of ICSI for all, and I think we are very happy.
That's wonderful. That's wonderful. That's so clearly defined and so clearly enunciated. Do you use testicular sperms even when you get ejaculate sperms?
See, there has been literature where there are cases of recurrent implantation failure or recurrent pregnancy loss. It is better to use testicular sperm, but personally, if we get a ejaculated sperm, we never go for testicular sperm.
Okay. Dr. Isha, any difference of opinion, or would you agree with either of the panelists? Because we had two completely different views from both the panelists here.
Sir, actually, I because since I've experienced 3 or 4 cases of fertilization failure, so I feel but for me, I go for all ICSI for all, because you are very sure that sperm will definitely enter, whether it has to fertilize or not. It is up to that. So my experience is that I would go with ICSI only. And the testicular sperms are usually, if there is adequate ejaculatory sperm is there, and if there is no evidence of like DFI, high DFI, then I would go for ejaculatory. But if there is severe oligoastenospermia, or if there is evidence of high DFI, then I would go for testicular. But so that's it.
It's again wonderful listening to all kinds of opinions. I would like to add here that there are literatures which says that ICSI children may have higher anorectal malformations and psychiatric disorders, especially born out of parents who are elderly. So it is my request, because in India we don't keep any kind of a birth registry, that all of you are doing such wonderful clinical work. Why don't you keep your own registry, so that over next 10 years or 15 years, when a large volume of work has been carried out by each of you, then we can actually honestly look at our work and come back with data that actually helps us to decide where all these that we are doing for our patients, whether it was meaningful or not. We would move to the next section now, where we would talk about different methods of sperm selection, as to how does one get into the process of selecting the right sperm, and for an ICSI or even for an IUI. Dr. Lubna, we subject all semen samples when we take them for any kind of ART, whether it's an IUI or an IVF, to centrifugation and a wash and a double density gradient. In a couple of words, can you tell us how does it help to select the right sperm?
Centrifugation, we separate the sperm actually from the seminal plasma and other things that are not necessary. We get the only sperm pellet, and that we examine and we use that as things. But the disadvantage is that centrifugation, there may be head damage of the sperm, and
because in
then
centrifugation we spin the sperms at high speed, so there could be damage that may be induced to the sperms, and there could be generation of ROS, which may again cause functional damage to the sperms. How do you select sperms through the method of simple wash or double density gradient?
Double density gradient, we are using two, they cannot pass it through straightly, and so they are trapped in any one of the layer. So only the highly
morphologically healthy sperms. So these are methods which can be employed by almost everyone in their labs to select the right sperm. What about MAX, IMSI, PIXI, microfluidics? These are all catchy acronyms that we hear quite often. Dr. Preeti, would you want to answer what is a MAX and how does it help? What is an IMSI? How does it help?
Well, MAX is a magnetic assorted cell system. In this, what we do is like it based on the principle that when cell membrane is damaged, there is a phosphatidylserine serine which is exposed. And there's a molecule which is called NX5, which has got a lot of affinity with this phosphatidylserine. So these in this test, what we do is we tag this NX5 with the nanoparticles, and we run the sample with a magnetic gradient. So it helps us to separate the sperms which are damaged.
That means stuck to the annexin beads, and the good sperms can continue.
Good sperms can continue, and we collect them in a way.
This is how technology helps us. Thank you for this nice, simple explanation. What about IMSI? What is IMSI?
IMSI is, in this case, we are morphologically selecting the sperms. In this, what we do is before doing the ICSI, we see the sperms under the microscope, maybe a magnification of around 6,000. And we are able to see the vacuoles.
In a standard ICSI microscope, the magnification is only about 500 times. So here we are optically enlarging the image and magnifying it almost 10-12 times more. So then we can look at the sperm in much greater details, right?
Yeah. So it helps in selecting those mature sperms.
Healthy, good-looking sperms. Have you implemented this in your practice, and does it make any difference in your practice in real sense?
Yes, I am doing a few cases where I'm finding teratozoospermia. In that case, I'm generally using this technology, and it has given me a good result.
Okay, so you think that this lessens your miscarriages and improve your outcomes. Dr. Mukesh, would you want to talk about PIXI? Are you using it in your practice?
PIXI is it's a physiological. P is for physiological ICSI. So what is done is the ordinary ICSI dishes are not used. Rather, a PIXI dish is used where you have hyaluronan microdots on the dish. So when you prepare the semen and put the semen drop in on those PIXI dots, so what happens? The most mature sperms, which express the hyaluronan receptors on their surface, go and attach themselves to the dots.
Functionally healthy sperms will attach to those droplets, and then those sperms can be selected and used for ICSI. Again, a very nice and simple explanation.
Commercially, the PIXI dishes are now available. Ordinary dish will cost you 500 rupees, and a PIXI dish costs you around 5,000 rupees. So that's it's a little costly affair, but I think it can be used.
And have you started using it in your practice?
This Cooper Surgical, they have been promoting it, and I think next now the business is down. Maybe post COVID we'll try using it.
Absolutely. Microfluidics also, I would say, works on similar principles. These are very fine channels that are there in the dish, and the sperms are expected to pass through these fine channels. So only the healthy sperms can pass through these fine channels and get collected at the end of this. So these are all methods to try and functionally and physically identify a healthy sperm, which can then hopefully give us a healthy embryo. This is one section that is very close to my heart, the genetics of male infertility. Remember, there could be issues in the genetic makeup of the man. He could be suffering from Y chromosome microdeletion or a congenital absence of vas deferens, or there could be this Klinefelter syndrome, and this is not as rare as we think. Almost 20% of our men who suffer from problems have either of these problems, and this is something that we have to keep in mind when we go for treatment of these couples. So we need to evaluate them for their genetic disorders. Of these, of course, the commonest method that we check them for is the karyotyping, which helps us to identify things like Klinefelters. But we also do what is known as Y chromosome microdeletion, and this is becoming fashionable over the time for severe oligospermic patients, and for azoospermic patients, we refer them for Y chromosome microdeletion. I would like Dr. Mukesh to explain in a few words, because we are running out of time as well, as to what is it that we check for in Y chromosome microdeletion and how is it clinically helpful.
Y chromosome microdeletion test is done in cases of either azoospermia, especially non-obstructive azoospermia, and also in severe OAT cryptozoospermia cases. Basically, the Y chromosome, we look for a specific segment of the gene called AZF segment, which is basically of three types, A, B, and C. So what we see is if whether there is any absence of any of the three segments, and if it is there, which segment is absent, because it has a lot of prognostic value. If the segment A and B are absent, then the chances of getting sperm surgically is also almost nil. But in cases of absence of segment C, the chances of retrieval is pretty good, around 50%. So, knowing the presence or absence of the AZF segment is very important, both to know whether we will be able to surgically retrieve the sperm or we won't be able to retrieve the sperm. If the segment C is present, again we need to counsel the couple that if the baby born out of the ICSI to that couple, if it is a male baby, then the chances of inheriting the same azoospermia is also almost 100%. So
Excellent,
that's
excellent. So this is again a
better
very
way.
valid point, that we need to tell them that if there's a male offspring, then this could be carried forward. Have you asked for the Y chromosome microdeletion test in your practice? What is the cost? What is that you need to send out? Is it the semen sample that you need to send out? Is it the blood sample that you need to send out?
No. We do it very frequently. Y chromosome microdeletion test is done by blood test, and I think it costs around 7,000 rupees.
Okay.
So it's not very expensive and reachable. And I think in cases of non-obstructive azoospermia, whenever you are doing a TISA for ICSI, I think it should be done.
I would also like to touch upon what is commonly
non-obstructive azoospermia.
what is commonly talked about as azoospermia, or absence of sperms completely. Any experience of having pregnancies out of these patients? How satisfying is that experience? What is the role of micro-TZ for such patients? Dr. Isha, would you like to elaborate about azoospermic men, how they can actually look forward for a pregnancy with their own gametes?
Actually, azoospermia can be divided into pre-testicular, testicular, as well as post-testicular. Since post-testicular is obstructive, so there are chances of retrieval of sperm from the testis. But
and those sperms can give us pregnancies?
Yes, and in non-obstructive, if it is hypo, there are cases where giving a gonadotrophins may lead to some kind of sperm in an ejaculate. But in non-obstructive, it's very rare. Like there are cases where it has been found out the chances of getting the sperm is around I think around 30 to 40% if we only do a micro TZ, because sometimes there are cases if we simply do TISA or TZ, the chances of getting are less. But in microsurgical technique like micro TZ, the chances of getting these sperm are higher. So,
I'll do a commercial plug here. I'll do a commercial plug here. Our resident andrologist has now trained in microsurgical method and will be starting micro-TZ in the Kolkata center from next month. This is just a commercial plug for my
I have no
benefit.
experience with micro-TZ as such, because most
But
of
very,
them
very soon you will have experience because you'll be starting in our center. So this basically sums up the azoospermic men. They are not as rare as we think, and at the same time, they are not as hopeless as we think. Most of these azoospermic men can still have their own children, because there is a very high probability that they are either suffering from hypo or they are having an ejaculatory duct obstruction. In both cases, they can be medically treated or surgically the sperms can be retrieved. And in a group where there are non-obstructive azoospermics, there also micro-TZ can help us evacuate some sperms, which can help us achieve a pregnancy. So they're not as hopeless as we thought they were previously. I would also come back to the point that I mentioned. Retrograde ejaculation is also someone who would give no sperms in the ejaculate, but when the urine is analyzed concurrently, then there are a lot of sperms that are seen because that person is suffering from a retrograde ejaculation problem. Dr. Mukesh, have you seen such patients and how do you handle such patients?
Retrograde ejaculation I have not got as yet. I know how to handle, but I'm still waiting to get one case.
Okay. Dr. Isha says that she has handled retrograde
Sir, I
ejaculation
had
patients.
a case one important thing is whenever which we have ignored is whenever we look for semen analysis of important thing is volume. You always with
Absolutely.
volume
Absolutely.
also you
Absolutely.
can make the diagnosis whether
Absolutely.
it's an obstructive or non-obstructive. And sir, I have seen cases the patient was a diabetic, so the volume was very less, and after doing the post ejaculatory urine analysis, there were plenty of sperm. But the patient did not go ahead with the process. He
Okay.
wanted to go ahead with donor because he was not very sure whether the
But
conception
there
would
are
be.
methods by which we
Yeah,
can
yeah, sir.
effectively collect the sperms and use them for an IVF or an ICSI.
Yes, sir.
The last couple of special situations that we are discussing, we are talking about male accessory gland infections and infertility. They have been acronym wise, they have been summed up as MAGIs or MAGIs. So, Dr. Isha, I'll stick to you on this as well. What is your plan of treatment of patients, men with semen infection? And do you routinely use antibiotics? What is your standard antibiotic dose and curriculum?
So basically, Maggie, like as you said, male accessory gland infection, it is the infection of prostate, uh, testis, seminal vesicle, as well as bulbourethral glands. So if there is any evidence of leukocytosis in a semen analysis, what we say is more than 1 million leukocytes in a semen analysis. So that indicates that there are chances of infection. So depending, and then if there is, so then we can go ahead with the semen culture or urinary urinary analysis, urine analysis also, and also a culture of prostate after prostatic massage, this sample what we get. So we can do the culture of those fluids and get to see the we get do the culture of this fluid to see what are the infecting pathogens, and depending on the pathogens we can go ahead with the antibiotic. Like mostly we give doxycycline 100 milligram twice a day for 7 to 10 days, or azithromycin single dose has also been given in order to treat this condition.
Okay. Dr. Preeti, I'll ask you to speak a few words about the possibility of the male contributing to recurrent pregnancy loss. This is something that we ignore as in current practice, but we would like to remind our audience that the man could also be responsible for recurrent pregnancy loss. And the reason why we are not able to check for this is because we don't do a routine DNA fragmentation. So, would you like to prime the audience about this?
Yes, there are so many causes of recurrent pregnancy loss, but generally we don't do extensive study in case of a male partners. But in case of recurrent pregnancy loss, I would definitely like to do male karyotyping in this case, and also evaluate the abnormal DNA fragmentation in this scenario.
Going forward, this may become a routine or a standard of care practice where we check the man also for pregnancy losses which happen in the first trimester usually. And a final few words on fertility preservation, how important it is in today's scenario to counsel our male patients if they're suffering from cancer to freeze their semen sample, because once they are treated, they can always come back and get a pregnancy with their stored sperms, because in most cases radiation and chemotherapy causes irreparable damage to their gonads, and they may be saddled with azoospermia or poor quality sperm for the rest of their lives. So would you like to tell us why is it important to freeze sample before chemotherapy or radiation starts? Dr. Preeti.
Before the chemotherapy or radiotherapy starts, I would like them to preserve the sample in order to have their own children with their own gametes. Because once the radiotherapy and chemotherapy is there, there is a damage to the testes, and then there is a spermatogenesis which get interferes, and also there is a ejaculatory dysfunction which take place. So if we have a few samples which are preserved before their chemotherapy starts, it will provide a hope for these couples to have their own children once the treatment gets over.
So it's very, very important to sensitize everyone around us that this is an easily done procedure, simply carried out procedure, widely available. It just needs to be propagated properly, that men should freeze their semen sample when they are counseled for radiotherapy, chemotherapy or surgeries, so that they can benefit from those stored semen as and when they desire to become parents. I have taken 5 minutes extra. Instead of 75 minutes, we have taken 80 minutes to close out the panel discussion per se, but we will take next 10 minutes for the rapid fire questions. The audience, as always, has been very generous and has bombarded us with questions which I now expect my August panel to answer one by one. Dr. Provat Kumar Bala from Kumila. He asks, would you please inform us about obstructive male infertility and the emphasis on vasography? Dr. Mukesh. You're not right.
The number one cause of obstructive agiospermia is congenital absence of vas deferens, where there is no the absence of the segment of the vas deferens and seminal vesicles. And other causes may be some infective causes, and basically this is congenital and infective. And vasography I have never done. I have no experience of vasography. And if it is a congenital absence of vas deferens, we need to go for the genetic test again to know whether genetic test of basically I do it of the opposite partner, the female partner, to know whether she is a carrier of CFTR, cystic fibrosis, transmembrane conductase gene. Because again, if you use the sperm from this male and ultimately the female is also a carrier, the child is again prone to develop the cystic fibrosis disease. So this testing for CFTR gene for the female partner in cases of absence of vas deferens is very, very important. But vasography I have no experience.
So a vasogram has to be carried out under anesthesia in an operation theater, and because it's a kind of an invasive procedure like an HSG. And usually it is not very popular because there are multiple blockages in most cases, as Dr. Mukesh pointed out. Because in infection, you would not have a single block. You would usually have multiple blockages. And then there are areas where the blockage is in a very fine lumen area. In some places, the blockage could be in a wider bore area. So while it may be possible to diagnose, it's hardly ever possible to treat effectively. So a single blockage in an accessible point can be treated surgically, but multiple blockages do not do very well with surgery. So while bypass surgery was common till some time back, now with better results and outcomes with ICSI, people have started discontinuing this. A similar question was asked by Dr. Mohammad Shah Alam from Borishal in Bangladesh. What should we do if there is a block in VOS? And we have answered that. Dr. Jannatul Fardoz Jasmine from Khulna. What is the hormonal treatment for severe oligospermia? And we have also discussed that. We have talked about clomiphene. We have talked about letrozole. We also give HCG in hypo. Dr. Isha, would you like to elaborate on that?
So in cases of hypo, we would give HCG for in a dose of 2000 to 3000 international unit twice a week for around 3 months, 3 to 6 months. Then again reevaluate if there is any evidence of increased sperm. Then we may add FSH also to it after 3 months, looking at the semen parameter, and FSH can be given once a week along with HCG, and then we can see the semen parameter after 3 months if there is an improvement.
Only thing we need to keep in mind that the therapy has to continue while the treatment is going on, because once we stop the therapy, the patient goes back to
hypo. It has to be continued.
Absolutely. Dr. Azaz Hussain from Dibrugarh has a question. Why is preterm labor so common in ART patients? Dr. Preeti, would you like to take this question?
Preterm labor common.
Anybody else in the panel? Dr. Mukesh?
It's a fact that preterm labor is very, because number one, the chances of multiple pregnancy is higher. chances
So
of
you have
interventions like
more incidents of multiple
hysteroscopy and
pregnancies.
previous cervical dilatations and right. Number one, multiple pregnancy. Number two, chances of interventions being done on that lady earlier. She may be having a lot of DNCs and hysteroscopy and all. Number three, you are artificially you are stimulating and the hormones in the body. We don't know the physiology of human body. It's a known fact that we lose a lot of pregnancies in mid trimester and late trimester.
So this is still a black box, but yeah, most of the points that we think are responsible is the fact that this is a highly treated, maybe sub-abnormalities existing in the reproductive tract kind of a patient, and there are higher incidence of multiple pregnancies. Another question from Dr. Dilip Buragoy from Dibrugarh. What is the role of clomiphene citrate? Dr. Mukesh has already explained that. Dr. Kamrun Nahar from Dhaka asks, what drug is prescribed in infertile men? We've also addressed that, letrozole, madam, clomiphene, and also HCG and HMG, as Dr. Isha pointed out. Dr. Sharbari Dey from Dhaka, Bangladesh. Actually, it depends on understanding between the client and clinician and counseling too. Whenever the duration of infertility is longer, the male partner is ready to get treated. Thank you for your comment. Dr. Sharbari also has another comment. Being a fertility specialist is not necessary to send patient to urologist always. I can perform examination after counseling and make the patient to take it easy. If extended evaluation needed, then maybe refer to urologist. A very, very valuable point, madam. Thank you for adding this note that it is not always necessary to send patients to urologist. As we are clinicians and we are capable of doing our examinations, we may do a basic examination for sure. Dr. Gaur Kishore Chakraborty, thank you for this amazing session. Thank you, sir, for your participation. May you please summarize the whole session as a take-home message. We have already done that. Dr. Mamta Bukalsaria from Dibrugarh, role of antibiotics and anti-inflammatory. Dr. Isha touched about the antibiotics. Does anybody use anti-inflammatory in his practice? Anybody in the panel?
Yeah, actually, all cases of inflammation may not be due to infection. Inflammation and infection are not synonymous. So there may be some patients who need anti-inflammatory. If there is a prostate is inflamed, the seminal vesicles are inflamed, epididymis is inflamed, you have to use the anti-inflammatory drugs and frequent ejaculation so that you get rid of the pus cells and the debris and all. So antibiotic with anti-inflammatory with frequent ejaculation is the way.
Thank you for your kind explanation. Dr. Kusum Dash from Bokaro. Is there any role for natural testosterone for improving count? Dr. Lubna, Dr. Risha.
So actually for testosterone is usually not given for improving count because it has a negative effect on secretion of gonadotrophins. So if there is evidence of any testosterone deficiency and if the male is not wanting for any fertility, then you can give. But if there are undergoing treatment for fertility, then there is no role of giving in testosterone.
Okay, thank you. Dr. Lubna, would you agree or you have any other comments?
Yeah, 100% agree. If they are wanting parenthood, we should not use testosterone for male infertility.
So we should never use testosterone for male infertility. It may be used for libido, for sexual dysfunction, but not for people who are wanting a pregnancy. Dr. Shupanna Bhattacharya, your opinion on the role of vitamin D in case of poor sperm parameters. Dr. Preeti, would you like to take this question?
Yes, we generally do give vitamin D in case of poor sperm parameters.
So she is using vitamin D also as part of the nutritional pack. Dr. Shankar Jaikishan Patel from Jharsuguda. It's an excellent discussion. Thank you, sir, for your comments. Jyoti Gupta from Bokaro. Is it possible that FSH is low but testosterone is normal? Dr. Preeti?
FSH is
low but testosterone is normal.
Yeah, it can happen.
Yeah, so in some cases it may happen, and in those cases we may benefit from clomiphene, as Dr. Mukesh pointed out. Dr. Poonam from Patna. Many patients have conceived with only mild male factor was the cause, and I do prescribe antioxidants. Thank you for sharing your practice as well. This is what is good about these panel discussions. We get to hear from everyone about the kind of practice that we are all doing. Dr. Binod Agarwal from Jamshedpur. Dr. Mukesh, question addressed to you. How can you explain a bad embryo coming out of ICSI?
Bad embryo out of ICSI?
Yeah.
There can be so many reasons. It can be a bad egg. It can be bad sperm. It can be bad technique. There's so many reasons. ICSI does not guarantee. ICSI guarantees you only a fertilization. ICSI does not guarantee you a good embryo.
Okay.
You have to have that distinction. Yeah.
Okay, so ICSI will take you one step forward, did not
Right.
give you the end result that we are all looking at. Dr. Poonam again has very nice comments to say about us. Excellent and very informative panel. Dr. Sharmishta Chatterjee from Konnagar, very informative discussion. Dr. Sharbari there from Dhaka, for pre-pubertal boys, we can even try testicular tissue preservation. Yes, madam, that can be done, but today it is experimental. It is not yet commercially sanctioned to be used for patients. And Dr. Shaista Iqbal from Ranchi, why is multiple pregnancy common in IVF? Dr. Isha, would you like to explain this?
So because usually for embryo transfer, the minimum, the transfer, now there is trend of single embryo transfer if we do a blastocyst. But initially when we used to do, when we are still doing day 3 transfer, so the minimum amount, minimum embryo we transfer is 2. So if both of it gets implanted, so there are chances of.
Okay, so because we want to enhance the outcome results, we still put back 2 or 3 embryos, which is why multiple pregnancy is pretty common. I would like to conclude here.
I want to.
Yeah, Dr. Mukesh, please,
just one
final
point.
words. Final
Chances
words.
of monozygotic twinning is also more in IVF.
Yes.
So once
So
I
also,
transferred 3 embryos and landed up with a quadruplet.
yes, so that is true that we also have spontaneous twinning also happening with single embryo transfers also. So which is why we see higher order of multiple pregnancies in our practice. I would like to come back and thank people at Science Integra, Bharat Serum, for affording us, giving us this platform to interact with our doctors, referring gynecologists, and the practitioners in this part of the country, Bangladesh, Nepal, Sri Lanka, Nigeria, Middle East. It has been a wonderful experience for the last 1.5 months. We would like to come back to all our doctors in some other form and format very soon. We are working on that. It has been a learning experience for me personally and also for my team. And I would also like to thank Dr. Preeti, Dr. Mukesh, Dr. Isha, and Dr. Lubna for taking time out and participating in today's session. It has been wonderful having you and having our doubts cleared. Thank you all.
Thank you.
Thank you so much.
Thank you, Dr. Rohit, for having me here.
Pleasure,
Thank you.
pleasure.
Thank you so
Thank
much.
you.
Thank you.
Thank you for